Hello, I am Dr. Padma Priya and I continue with session 2 on newer anti-TB drugs and regimen. Anti-TB drug for drug resistant or MDR-TB has been reclassified or regrouped into group A, group B, group C and group D. Group A consists mainly of fluoroquinolones, levo, moxi and gatifloxacin. Group B consists of second line injectable drugs, amikacin, capreomycin, kanamycin along with streptomycin. Group C are the other second line core agents, which includes ethionamide, prothionamide, cycloserine, linezolid and clofazimine. The group D are the other add-on drugs, pyrazinamide, ethambutol and high dose isoniazid, the newer drug bedaquiline and delaminid, and the D3 class of drugs including PAS, imipenem and amoxiclav. In the next few slides, I want to describe the various trial regimens which have used a combination of newer drugs. The first one is a PAMZ regimen. This is a phase 2b open label efficacy and safety trial that is combined moxifloxacin, pretominid and pyrazinamide for a period of 8 weeks. They have tried to look at the bactericidal activity of this particular regimen and they have seen the reduction in the colony count of M. tuberculosis. Now, if you look at this table, the study arm which contained this particular combination of PAMZ has shown a reduction or time to culture conversion is much faster or much earlier than the regimen which did not contain the newer drug pretominid. It is around 28 days in the solid culture as compared to 35 days in the control regimen. The 8-week culture conversion again was around, if you look at the proportion of patients who showed culture conversion at the end of 8 weeks of treatment, around 94% was seen in the regimen containing 200 milligrams of pretominid as compared to 88% in the control arm. Now, based on these earlier findings of culture conversion at 8 weeks, the group went on to do a controlled clinical trial among 350 patients and looked to see whether they can shorten the treatment duration to 4 months instead of 6 months. They have got two different arms. The one group is all drug sensitive TB, where they are comparing the pretominid of 100 milligrams versus 200 milligram in drug sensitive patients as compared to the control regimen of Rifampicin. Now, this regimen is given for a period of 4 months versus 6 months. They also have an observational arm where they are giving 200 milligram of pretominid along with moxifloxacin and pyrazinamide in drug resistant TB. This is an observational cohort, observational group, and the treatment is going to be given for 6 months and see the response at the end of 12 months and 24 months. They are looking at outcome of incidence of combined bacteriological failure or relapse or clinical failure at the end of 12 months from start of therapy. The next trial is the next trial. The next trial is nothing but a phase 3 prospective open label randomized clinical trial looking at a combination of newer drugs bedaquiline, linezolid, levoflox and ethionamide along with pyrazinamide in drug resistant TB patients. This combination will be given for a period of 6 to 9 months. Important thing to note here, there is no injectables in this regimen. The regimen will be given for 6 months in MDR TB patients, can be extended up to 9 months in case of failure of culture conversion at the end of 4 months of treatment. All the patients will be followed up for a period of 24 months after initiation of treatment to look for the treatment success in terms of failure as well as relapse. The study is currently enrolling patients and we expect the trial to get completed by 2019. Another trial that is being tried for extensively drug resistant TB patient is by combining two new drugs. So, whatever we have seen so far is a combination of one new drug with existing drugs. Now, we have two new drugs in the regimen, pretominid 200 milligram once daily along with bedaquiline in the recommended doses after the loading dose of 400 milligram, 200 milligram to be continued thrice weekly. These two new drugs are combined with linezolid at the dosing of 1200 milligram once a day. Now, this is being tried out in extensively drug resistant and pre-extensively drug resistant TB patients or those who have failed or are intolerant to DRTB treatment. The whole duration of treatment is for 6 months. It is a non-injectable fully oral regimen. Patients will be followed up for 24 months after completion of treatment to look for the presence of failure or relapse. So far the results that we have from NIXT-TB trial, 61 participants have been enrolled, 79% of them happen to be XDR TB and the remaining are pre-XDR patients. 34 patients have completed 6 months of treatment. Among them 4 have died, the remaining all have become culture negative as early as 4 months of treatment. Further results are awaited from the study. Now moving on from those newer drugs to the drugs using fluoroquinolones. Now this is a short course regimen that has been tried in Bangladesh. Now this graph here, it shows the various regimen that was tried in the Bangladesh regimen. The first one is an ofloxacin 1 and 2 or ofloxacin based regimen along with pyrazinamide, isoniazid and other classes of groups of drugs. Regimen 3 is ofloxacin based without isoniazid. The regimen 4 is again pyrazinamide, INH, ofloxacin based regimen. If you look at the regimen 6, they have replaced ofloxacin with gatifloxacin drug along with pyrazinamide and isoniazid in the intensive phase and clofazimine added on to the regimen and continued throughout the continuation phase. Now if you look at the success rate at the end of 6 months of treatment, the regimen that is used gatifloxacin has a treatment success rate of around 88% as compared to other regimens which vary somewhere between 56% to 80%. Now the most important thing to note here is the presence of isoniazid. If isoniazid was added to the regimen, the success rate was higher as compared to regimen we did not have isoniazid when it was given along with ofloxacin. The graph below shows the response to treatment. Now gatifloxacin regimen had a very lower rate of adverse events as compared to ofloxacin based regimen. The hazard ratio of when patient remained toxicity free or absence of toxicity was higher in a gatifloxacin based regimen as compared to a ofloxacin based regimen. Now looking at the success of this 9-month Bangladeshi regimen, many countries wanted to adopt this regimen and there was a study that is done at 3 or 4 countries and they replicated the same regimen in MDR-TB patients in multiple countries. So this is a result of the 9-month Bangladeshi regimen among MDR-TB patient in 500 MDR-TB cases in multiple countries. Now if you look at this graph here, this is the success rate of culture. So the culture, there is more than 85% of culture conversion, and if you look at this graph, the third graph, it is a smear status. So the same time point, at the same time point when someone shows culture conversion, they could have been smear positive. So what we want to say here is there is a lag between culture conversion and microscopic results. The second month there is 93% of culture conversion as compared to the smear conversion which varies anywhere from 27% to 73%. Hence if a patient is supposed to be on a shorter course regimen, it is mandatory that it is followed up with culture conversions and not just to smear conversion alone. Now based on the results of the short course regimen in 500 MDR-TB patients, WHO has recommended the use of shorter MDR-TB regimen. Now what is the criteria or who are the patients who are eligible to get a shorter MDR-TB regimen? Look for the presence of resistance, confirmed resistance or suspected ineffectiveness to a medicine in the shorter MDR-TB regimen. Have they been exposed to more than one second line medicine in the shorter MDR-TB regimen for more than a period of 1 month? Is a patient intolerant to more than one medicine in the shorter MDR regimen? Presence of pregnancy, presence of extrapulmonary disease or at least one drug which is not available in the program. If the answer to any of these questions is yes, the patient is not eligible for shorter MDR-TB regimen and what he has to get is an individualized conventional MDR-TB regimen consisting of an intensive phase and a continuation phase. The IP here is for a period of 8 months followed by continuation phase for a period of 12 months. Now if answers to all these questions given here is a no, then the patient becomes eligible to receive a shorter MDR-TB regimen. The shorter MDR-TB regimen is for a period of 9 months, 4 to 6 months of intensive phase and 5 months of continuation phase. The 4 to 6 months of intensive phase will have 4 second line drugs. The 5 months of continuation phase will have 2 second line drugs. So in short, the IP will have 4 to 6 months of kanamycin, high dose moxifloxacin, pyrazinamide ethambutol along with clofazimide, prothionamide and high dose H. The continuation phase, they get 5 months of high dose moxifloxacin along with pyrazinamide, ethambutol and clofazimine. The meta-analysis from the shorter MDR regimen has shown about 796 patients who received the shorter MDR regimen in 5 countries, they had a success rate of 83% against the current success rate of 30 to 50% with the conventional 24-month regimen. The failure and relapse were more frequent in individuals who were treated with moxifloxacin, strains which were resistant to pyrazinamide or any of the fluoroquinolones, and absence of culture conversion by the end of 2 months of treatment. Based on the results from shorter course regimen and seeing the success of fully oral regimen, few other investigators have gone on to plan other trials combining two newer drugs or other repurposed drugs. One of such trial is NTB clinical trial. NTB stands for evaluating newly approved drugs for multi-drug resistant TB. Here there is a combination of bedaquiline delaminid, the two new drugs, clofazimine and linezolid, these are repurposed drugs, as well as fluoroquinolone and pyrazinamide antibacterial drugs are being used for drug resistant TB. They have 6 arms in various combinations. This is given compared along with individuals who will receive a control regimen. The control regimen is the WHO or the country-wide program regimen. Another trial is the NTBQ trial. The NTBQ trial is for patients who are fluoroquinolone resistant. This has 2 arms combining bedaquiline delaminid with clofazimine and linezolid given for a period of 6 months to 9 months, and this will be compared with the standard of care control regimen as per the WHO guidelines. Now, many countries have been including delaminid and bedaquiline in their national programs, and if anyone starts on a delaminid or BDQ containing WHO guidelines regimen, they will also be included in the study. So, this is there will be 500 randomized participants in this trial, and the trial is yet to begin in few countries. Stream 1 stream is an evaluation of standardized treatment regimen of anti-TB drugs for patients with MDR-TB. This is there are 2 phase stages to this trial. The stream 1 is a phase 3 clinical trial. It will compare the WHO MDR-TB regimen with a 9-month Bangladeshi regimen with a slight modification where gatifloxacin was used for in the Bangladeshi regimen. It will be replaced here with moxifloxacin. 421 patients have been recruited to the study. The success rate shown so far is 78% in the test arm as compared to 80% in the control arm. The stream 2 is a phase 3 clinical trial. With the advent of bedaquiline and availability in many countries, they have added 2 more regimen to this trial. It will compare a 6 and 9 month bedaquiline containing regimen against the WHO control regimen and the Bangladeshi regimen. The primary outcome of this study is to look at week 76 of the proportion of patients with a favorable outcome in the multiple regimens. So, the same trial regimens are: the regimen A is a WHO approved MDR-TB regimen. This will be compared against the regimen B, C and D. The regimen B will have an injectable in the regimen. It is kanamycin isoniazid with prothionamide, moxifloxacin, clofazimine, EMB and pyrazinamide. Regimen C is a fully oral non-injectable regimen. It has bedaquiline, levoflox, clofazimine along with INH, ethambutol and pyrazinamide. The regimen 4 again has an injectable in the regimen, but it will also have bedaquiline. So, it is kanamycin, isoniazid, bedaquiline along with levoflox and clofazimine. Now, most of the regimen A will be continued for the entire 24 months. The regimen B will be given for a period of 40 weeks, whereas regimen D, which has kanamycin as well as bedaquiline, will be tried for a period of 28 weeks. All the patients will be followed up for 12 months post treatment. Newer trial initiated by India and the ICMR is a BEAT trial. The BEAT trial is a non-injectable all oral short course regimen for extensively drug resistant and multiple drug resistant TB patients. This trial will look at the combination of bedaquiline, delaminid, linezolid and clofazimine, 4 drugs to be given daily for a period of 6 to 9 months. It has 2 phases to this trial. In the XDR and pre-XDR TB patients, the prospective cohort of 155 patients at 6 sites in the country. The MDR TB trial will have, it is a phase 3 parallel arm open label randomized clinical trial. There are few challenges in the new drug development as well as new drug regimens. Greatest challenge is the design of the TB clinical trial. A phase 3 clinical trial has to be done on a large scale with large number of patients, has to be randomized and multicentric. It is not only expensive, but also challenging to do this trial in multiple sites in a uniform fashion. Efficacy evaluation requires relapse rate to be the end point. It has to be done for a period of 1 to 2 years after treatment, and these patients have to be followed up after the completion of treatment. The drug development in children is a ball game of its own along with HIV infected individuals. There is also always the fear of drug usage or misusage in the private sector. So, with that we come to the end of session 2 of new anti-TB drugs and development. Thank you.